Thank you, Dr. Tompkins. And I'm very happy to be here on Doctor's Day. Happy Doctor's Day to everybody. I actually was reminded of it by the auxiliary when I came in. Thank you very much for my corsage. You know, the theme today is Medicine 2017. Can we survive it, right? Yes, we can survive it. But we have to do it with intentionality. And so one of the things I'm going to be talking about today is how do you work with a medical services organization to survive the current environment that we're in. So the title of the presentation is Using an MSO to Provide Patient-Centered, Whole-Person Care to Health Disparity Populations, which I know a lot of us in here do. So we know there have been a number of challenges to delivering health care in the past few years. There are increased demands on providers in terms of documentation and requirements and regulations. We just heard all about from the Medicare auditing standpoint. And all the acronyms that go along with it, MACRA and PHM and APMs and MIPS and PQRS. And then at the same time, many of us provide services in communities where it's a challenge to stay healthy, right? A lot of our populations live in food deserts, where it's difficult to have an environment in which you can get healthy, nutritious food to help support your health outcomes, which are expected. The environment in which people live in sometimes not only makes it difficult to support health outcomes, but may actually be responsible for the toll on their bodies and their health that make their health outcomes worse. And then there's also the inappropriate utilization, which can come about really from just simply not being able to get the time off work to go to your preventive care visit, letting a problem build up to the point where you end up having to go to the emergency department, or you might have child care issues as another example that prevents you from being able to proactively take care of your health. So all these challenges are on both sides, both to the physicians and to the populations that we serve. And we all kind of know the story, why there's been a need for payment reform, an aging population with more chronic disease, skyrocketing healthcare costs, and you know, really us practicing in silos and causing repetitive services to be happening and not a lot of care coordination going on. And at the same time, there are forces that have enabled a shift away from the way that we've been practicing, namely policy, the ACA, and now MACRA, which I think we heard about a lot earlier today, and then increased access to clinical information through technology that allows for coordination of care, connectivity between payers, consumers, and care teams through tools of population health management tools and patient portals, and then regional health information exchanges, again, that allow us to be able to know when our patient has gone to the hospital, when they've been transferred, when they've been admitted. And then at the same time, we have the triple aim, which actually was defined by the IHI in 2007. It's been 10 years now that we've had this concept of what we're striving for, which is improvement in the patient experience of care, which a lot of times people interpret as simply patient satisfaction, but that's not really what it is. It's really about providing safe, effective, patient-centered, timely, efficient, and equitable care to patients. And also improving health outcomes. So using population health, which is the methods and tools that are used to assess and improve the collective health outcomes of a group of individuals. And using those methods, it allows you to ask questions like, who is my population? And being able to define that proactively and understand what their risk level and their challenges are. So for example, I have 70 diabetics who have an A1C over 9, or I have 85 people who went to the ER more than twice last year. Or I have 70 individuals in my population who smoke. And then being able to define your population by their risks, and then being able to understand, therefore, what their care needs are, and matching your resources and your programs and your practice to what their needs are to try to improve their health outcomes. And then finally, how do you know that you're making a difference? You have to be able to select the measures that are necessary within your practice to know that you're making a difference and collect data on those results, which the payers want, so that they know to reward you for what you're doing. And again, a lot of us have been doing this over the years in many ways, shapes, and forms, but now there's a concerted effort to collect the data to show that you're doing what you're doing and improving health outcomes. And I think I have some slides in here about MACRA, but I think you probably have been macroed out today by the previous speakers. So I'll simply say that we all know that MACRA is an example of shifting from volume-based care to performance-based care, that there are two options for you to participate as an eligible provider. Number one, under the merit-based incentive payment system, which community-based physicians really would fall under that category unless they've elected to be a part of an alternative payment method. And I'm going to just go ahead and skip through these because, again, I assume you all probably teach me about this, given what you've heard already today. And just focus on the fact that the clinical practice improvement activities under MIPS are some subcategories that include things like expanded practice access, population management, like we talked about before, care coordination, beneficiary engagement, so really engaging your patients in their care and helping them to be more empowered when it comes to their own health, patient safety and practice assessment, and then of course participation in the APM. And you know, when we talk about, let me just go back to the previous slide, when we talk about population management, care coordination, and engaging your patients, it's kind of impossible to do that without acknowledging the fact that 70% of health outcomes, as we kind of talked about before, occur outside the walls of your practice. So those are things like the social determinants of health, health behaviors, and the environment in which people live. And I like this particular slide that talks about social determinants of health because it really also includes stigma and discrimination as a social determinant of health. I was struck by a study that I read. I'm also in genomics, and I'll be giving a talk about that tomorrow. But a study that I read that talks about the fact of the change in telomere length. As you remember from your microbiology course, telomeres are the end caps of DNA, and they shorten microscopically every time the DNA replicates. And there was a study that was done and I'm sorry, it's a sign of aging. So the longer you've been around, the shorter your telomeres probably are, and it's also a sign, too, of chronic disease and abnormal stress. So there was a study done in African American men where they looked at their telomere lengths, and they also asked them about their experiences with racism. And they found that those people who self-reported at higher rates of experience with racism, but who internalized and allowed that to affect their self-image, had abnormally shortened telomeres, as opposed to individuals who did not, who may have reported the same amount of exposure to racism, but they did not allow it to affect their self-image. They actually had normal or even enhanced length telomeres for their chronological age. So again, racism as a social determinant of health is real. So given all these challenges that we have, both on the physician side and then in the populations that we serve, how can we come together as physicians to really be effective in providing care and really keeping up with the changes in the healthcare environment? So that brings us to the role that an MSO, a medical management services organization, can play. So MSOs assist physician practices with basically the administrative challenges that you have in running your practice every day and keeping up with the healthcare environment. It takes advantage of the economies of scale to provide expertise and increase bargaining power for contracts and supplies, and then are attractive to physicians who don't want to be employed. You know, a lot of us went into medicine so that we could maintain our autonomy, and an MSO structure allows you to maintain that autonomy and not be an employee, and actually have a meaningful role in contributing to the direction of the organization through leadership positions. And these are just some of the list of management services that are available. You know, looking at from anything from hiring to credentialing and coding and billing, to procuring office space, equipment and technology, of course, of group purchasing that we talked about, strategic planning, which include actually participating in grants and contracts. So the MSO that I'm about to talk about, one of the things that we've done just in this year, we've been included in 3 grants, one of which has already been successful. And that specifically speaks to health literacy, and the other 2 have to do with genomics. And so the MSO helps you to redefine your workflow to optimize financial and clinical efficacy. And that includes, you know, setting up registries, maximizing the use of your EHR for data capture and patient tracking and outcomes review, and really helping you go granular with your coding and documentation to maximize reimbursement, to organize the care team and increase the efficiency, have identity, but it should be efficiency of your workflows. Identify efficient workflows. And for an example of that, having people work at the top of their license. So, for example, your medical assistant could be interviewing patients about whether they've quit smoking or not, and providing some smoking cessation counseling for which you can bill. And that's having that MA practice at the top of their license and at the same time fulfill a HEDIS measure. And then increasing patient engagement, extending office hours, open scheduling, and using new visit formats like group scheduling, which when you have a virtual practice, you might be able to do. So the Medical Home Development Group is the MSO that I'm with, and together the administrators have over 75 years of experience in things like process improvement, population health, NCQA, PCMH, PCSP, and PCC standards coaching and training. And what we've done is really build a virtual group practice in the DC, Maryland area. So we've been accepting provider practices that are interested in joining us, that are already established, but want these additional services. And at the same time, setting up new locations so that recent graduates who, you know, previously it's been cost prohibitive to just walk into a practice can do so. And also providing a bridge for doctors who want to retire from practice to be able to turn their practice over to a recent grad seamlessly, because it's been getting more and more difficult to sell your practice. So how do you make sure that you're still able to realize the benefits by having a recent grad come in and still be a part of the MSO and still get financial gain from the work that you've done all those years? And then also nurse practitioners who are looking for places to practice as well. And our particular strategy has been to work with the 1065. So this graph is taken from Uwe Reinhardt's work that talks about 10% of healthcare spending, or 10% of high utilizer patients, those who account for most of the spending, are accountable for 65% of all spending. So we've chosen to go after taking care of that 10% of patients who are high risk and who we can show the greatest impact in changing outcomes and changing spend. So one way that we've done that is really to try to locate practices in areas of DC that are medically underserved. So this is just an example showing psychiatrists, and the distribution on the left-hand side is where all the psychiatrists are. On the right-hand side of the screen, if those of you know who DC, who know DC, Ward 5, 7, and 8 are the medically underserved areas, and that's where all the need is, and all the psychiatrists are on the opposite side of the screen. So this is just an example of some of the providers and administrators that work with us. We're truly multidisciplinary. We have behavioral health providers, licensed clinical social workers, psychiatrists, and psychologists. We have addiction medicine specialists. Some of you might recognize Dr. Chapman. He's going to be speaking later today. We have cardiologists, Dr. Davidson, as well as internists, pediatricians, and family medicine practitioners, and rheumatologists as well, and nurse practitioners. And we're really in the process of building a medical neighborhood through this virtual practice. So we actually just started working with pharmacists who are going to be doing medication therapy management for us by being integrated into our chart, our EHR. We have the specialists that I already talked about. We're working closely with the Medicaid HMOs in the district to negotiate richer contracts. We have community and social services, which I'll talk about on a later slide. The primary care clinicians I've already mentioned. And then we have partnerships with United Medical Center, which is a hospital in Ward 8, which is the same neighborhood that one of our new practices are located at. And also we are opening a practice at United Medical Center as well. And so I mentioned the community and social services. We're working with an organization called Leadership Council for Healthy Communities, which is a 70-church consortium or faith-based institution, actually because there are some Muslim, mosques that are involved as well. And so we screen for social determinants of health using electronic means, and at the same time, that consortium also has the same software, so we're able to, at the same time, screen for needs, identify those places in the community where they can be fulfilled, and make those referrals electronically, and know when those referrals are fulfilled, when people actually show up on the other end, because we're sharing the same software. And we have nurse case managers who do our care plans, which is a requirement under Medicare for some of the advanced billing codes. We have peer support specialists, which are a special designation. They're like community health workers, but they're trained by the Department of Behavioral Health. We have several patients with substance use disorder, and so they're specifically there to help those individuals navigate the healthcare system. I've talked already about our mental and social health, but we also use televideo based on a model by Dr. Chapman, which he's going to talk about later today, that allows the patient right in their visit, their primary care visit, to be able to link to specialists without ever leaving the office. And again, I mentioned I have a genomics connection to Howard at the National Human Genome Center. With our pharmacists, we're also looking at using pharmacogenomics to inform medication therapy management. So helping to customize the treatment for people who are on multiple medications and therefore at risk for adverse drug events. And then of course we collect outcomes on referrals, healthcare utilization, and preventive screenings. Again, the picture of DC, these are all the Medicaid patients in DC. You see where they all are, you see where they're not. And then our new site in Ward 8 is Wingate, and Benning Road is our existing site, which is right on the border of Ward 6 and Ward 5. And then you see some of the churches that we're working with, how they're sort of interlaced throughout Ward 7 and 8. And that's one of the places that we've expanded care. I mentioned the Wingate. This is the Wingate Towers. Over 700 families live there, which is about 1,000 individuals. This is subsidized housing, so many Medicaid patients live here, and our newest location, is located on the ground floor of this building. This is just a shot of the inside. And then I mentioned Dr. Chapman using televideo, and we're using this model to expand access to specialists. And of course, our team huddles for care coordination, which take place in person and also by televideo and by phone. Partnering with the LCHC for the care coordination in the community. And then working with the payers to put on wellness days is an example of basically what they do is they look at their census of beneficiaries and using data analytics see who hasn't been to the doctor in more than a year, and then they will direct those patients by zip code to your practice, and have a care manager there from the MCO to be able to sign people up for you to be their PCP. And I'm just going to close by giving some examples, 2 examples of programs that we're going to be participating in. Today we just put in the application to participate in DC Healthcare Finance, which is the Medicaid organization that manages Medicaid in DC. Their Health Homes 2 program, which is mandated by CMS, is similar to MACRA in that if you're a Medicaid patient with 3 or more chronic illnesses, which those chronic illnesses can include mental health diagnoses and substance use disorder diagnoses, you are then able to participate in Health Homes 2, and you will be attributed to the doctor who you've seen the most in the past 2 years. So we're anticipating getting about 400 patients through this program. It requires that you have a care team put together that consists of a pharmacist, a nurse case manager, a care coordinator, a Health Homes 2 director, and a peer support specialist. And it reimburses for those care coordination services that you provide on top of your fee-for-service that you receive. And then after year 2, it adjusts payments based upon tracked patient outcomes. Another example of something that we're embarking on is the patient-centered care transitions for substance use disorder. This medical home development group was really led and patterned in large part on Dr. Edwin Chapman's practice, which I'm not going to steal his thunder. He has a whole presentation about all the wonderful things that he's been doing over the years. But one of the things that we're focused on, obviously, because he's an addiction medicine specialist, is springboarding off of his expertise to do innovative work. So we're partnering at United Medical Center in their emergency department, and I'm an emergency physician, so this is near and dear to my heart, to look at, and I see emergency physician in the audience too, to look at patients who've come in who've overdosed on opioids, and based on an outcome of a study at Yale where they got the first dose of buprenorphine, which is a partial agonist used to treat opioid use disorder, they get their first dose in the emergency department, and then they have a peer navigator who then takes them and arranges for a next day follow-up in the clinic that we have there on site, which is specifically an addiction medicine clinic. And they have over 100 overdoses of opioid use disorder a month. And so we're anticipating that this program is designed to really be a patient-centered medical home for individuals with opioid use disorder and see if we can make a dent in health outcomes there. Already talked about that we're using population health reporting tools to track HEDIS measures and receive electronic notifications from our regional health information organization called CRISP. And then finally, we have 2 other innovative programs. We just got funded, I mentioned, a grant to put on health literacy classes at the Wingate site where the 700 families are, and also working with Delmarva, which is the quality information network in this area from CMS. They put on free diabetes self-management classes. So we'll be having all those classes running throughout the year at the Wingate site for health literacy. And finally, we also got to participate in the Fruit and Veggie RX program, which is a program where physicians can write a prescription. The patient takes the prescription to a farmer's market and gets a voucher to get free produce. And in order to qualify for the program, that patient has to both have evidence of food insecurity and also have a chronic disease that can be impacted by nutrition. So I'll stop there and take questions and just say, the NMA physicians for years have already been understanding the concept of health equity, but we have to do a little bit more for our populations to make sure that from a health perspective, they're able to thrive and do well. And so I think the MSO now gives us a framework to be able to band together, do this in an efficient and effective way, and be recognized for our work. Thank you. Oh, I'm sorry, question, sure.
is our practice in Pennsylvania. You may, the reimbursement may be different in DC. Because you mentioned fee for service. Your Medicaid is fee for service?
So we have a couple of models. We have a large population of fee-for-service still in DC, but most of the patients have been switched over to Medicaid MCOs. And those MCOs then provide payment, and we're working with them to look at various value-based payment options. They're participating in the Health Homes 2 program, but not all of their patients are going to be in the Health Homes 2 program, so we're working with them to look at ways of doing value-based care with the remaining ones.
Because that's it. The model is great. There's a lot of work involved. Of course, the concept that we as clinicians have is that we prevent things through practice wellness.
Mm-hmm.
And if we, of course, have a follow-up, then everything's being done. But it's also work intensive. So hopefully the reimbursement aspect is commensurate with the work that's required.
Exactly. So I think there are a couple ways that we're addressing that. One is, like we said, it's a group of doctors, right? So therefore, they're able to hire this administrative staff, which is sort of like the CEO, the CFO, the CIMO, that you might have at a federally qualified health center. But because of the economies of scale of everybody banding together, it then becomes realistic to hire these additional people to do this work. Secondly, I talked about the increased efficiencies that are realized from becoming a patient-centered medical home. So we have the NCQA content experts on staff to help people become patient-centered medical homes and really improve your billing and coding so that you are able to gain additional reimbursement. So for example, one of our practitioners has already realized doubling their reimbursement and going home earlier, so seeing less patients, just from improved practice efficiencies. And then thirdly is the negotiation of contracts, negotiating those richer contracts, from a group perspective, in recognition of the fact that we're doing more work. So I think those are sort of the three areas in which we're addressing that issue. But that's an excellent question. Any other questions?
Well, thank you very much.